Hello, I'm Frank van der Veerdon, internist infectious diseases from Radboud University. And today I would like to talk about targeted cytokine therapy in COVID. My potential conflicts you can see here. So when COVID hit our hospital and there were reports from China and Italy was coming up, we already had the idea that similar to influenza, this viral pneumonitis could come with a very hyperinflammatory status. That time point in the Lancet, it was made clear by several experts that corticosteroids would probably not be the best choice, and we had to look for other strategies, targeted strategies. So with that in mind, we started looking into what would be the signature of a COVID and how could we target that. A few weeks later, it was published that we could think that there was a cytokine storm underlying this COVID, and it was proposed that targeted treatment with cytokines like targeting IL-1, IL-6, or even JAK inhibitors would be an option. At least we knew at that time point that there was a hyperinflammatory status, and we started thinking about what could be the possible pathophysiology behind this hyperinflammatory response. So to do this, we started learning also more the disease. When we saw the disease and what kind of stages it had, it became clear that we started getting an idea of what to target and when to target. So obviously, if COVID is not yet there, there are several strategies you can do, like vaccination or heterologous vaccination, like train immunity with BCG or prophylactic antivirals. At the stage where there is disease, there are symptoms, the next step we would have, or we would need, good antivirals. That is obvious, and there are some reports obviously about the remdesivir at this stage, but we do need at least some of the antivirals. And the second is that when the disease progresses, despite these options and treatment, the first thing we notice is the pulmonary edema, even without the patients being in this very hyperinflammatory status. And we have the idea that there is some sort of vascular leakage going on, at least maybe at the endothelial level, and we have some thoughts about that. But the stage at which I would like to talk about targeted cytokine treatment is the stage thereafter. After that pulmonary edema, hypoxia, the patients start presenting with either an improvement of their disease, or they go into a more hyperinflammatory status. And this is the critical point where we see the patients going into the ICU, or at least some of them will then also recover. So at that stage where the hyperinflammatory response becomes very obvious, we think there is an option for targeted cytokine treatment. Later on, there will be much more complications, for example, in the ICU with thromboembolic events, fibrosis, etc., and then it becomes much more complex. So the window where we think this strategy of cytokine targeted treatment, what we are talking about today, is at the gliding scale from pulmonary edema into the hyperinflammatory response, which will, for some, end in the ICU. Now, to do this, the first thing that we did was we started comparing the severe ICU patients with the patients that were admitted at the ward, and we started looking what is different, what kind of signatures can we find. And similar to many others, if you look at this volcano plot, on the right side, you see what's elevated in the ICU patients compared to the ward patients. On the left side, you see what was lower in the ICU patients compared to the ward patients. One of the obvious things that was immediately clear was that IL-6 can vary prominently out there together with some other chemokines. Together with this, we noticed that there was also a downregulation of stem cell factor and IL-7 receptor, mainly proteins that are driving lymphopoiesis. So now we have a more innate signature, which was elevated, and we had something on lymphopoiesis, the adaptive immune system, which was sort of suppressed. In addition, we saw proteins that were in a very different cascade, like SERPIN A12, DPP4, being also involved in kallikrein-kinin system, and maybe this was a hint for the vascular leakage. So we found basically three pathways that immediately came up as very striking. So when we put this together in the initial stage, this was very at the beginning of the COVIDs when we analyzed those data, we had the idea at least there is a very strong innate immune pathway with chemokines, cell infiltration, monocytes, neutrophils, giving the influx in the lung, together with an adaptive immune system that seems to be impaired either by an impairment of the lymphopoiesis, for example, or due to sequestration, and also maybe nicely explaining the lymphopenia that we observed when the patients became more ill. And on the other side, there was complement activation, kallikrein-kinin system was activated. Maybe this was a hint for the more vascular status of the disease. These three pathways made us think of what would be now a logical step to target in the treatment of COVID. One of the things that was also striking was that, for example, in influenza or in diseases like in sepsis, there is a component which we call the autoinflammatory loop. And we thought this is something to target also in COVID. It's not the whole story, but it could be a very prominent and important component. I'll try to explain what we mean by this autoinflammatory loop. So when monocyte macrophages are seeing initial triggers, for example, with coronavirus via TLR7, they will induce pro-IL-1 beta, which is a cytokine that is induced, but it's not active. It's not biologically active. You need a machinery like the inflammasome, which is a protein complex that will activate and cleave this cytokine, and then IL-1 beta comes out of the cell. Once it's out of the cell, it does many things. For example, it will induce IL-6, and that will lead to increased CRP, but also it will attract neutrophils, monocytes at the site of infection, and there will be fever due to the IL-1. There will be elevated ferritin levels reflected as the IL-18 will be increased also due to the inflammasome, and CRP as a reflection of IL-6. So IL-1 will coordinate a lot of those innate inflammatory responses at the base of where it all starts. Now, one of the other important things about IL-1 is that it can induce itself, and this we call the autoinflammatory loop, meaning that if IL-1 is there, it can induce the same cell and keeps itself activated so that the inflammasome is activated and this process is continuing. Once IL-1 induces IL-1 and this loop is not broken down or controlled, for example, by the adaptive immune system or other systems, then this will continue and there will be a continuous inflammatory response of those monocyte macrophages. We and others have found that the IL-1 signature in COVID is very clear in the lung, and you can look at the infiltration of neutrophils and monocytes, which tell us that there is a strong evidence that this might be happening there. It's also important to notice that this loop can be fed from other sources. For example, if there are dying cells like neutrophils next to the IL-1, next to the monocytes and macrophages themselves, they can also trigger via pattern recognition this induction. And IL-1 alpha that comes out of the damaged cells like endothelial cells or epithelial cells can also feed this loop. So together, this is a component that is much more universal than just corona, but it could be a very important one given the fact that we see much evidence of this loop being there. You can also see that when you now look at this, know where to target. So for example, you can target this by giving the drug anakinra, which is a recombinant IL-1 receptor antagonist, which will block the receptor. And by doing so, it will stop the loop. You can also notice and appreciate from this depicted figure that it will do something on IL-6, but if you would, for example, block IL-6 or something like interferon gamma, you would stay out of the loop and you won't do anything on this autoinflammatory loop, on the status of this very activated monocytes and macrophages recruiting more neutrophils. So we think this is one of the much more basic targeted factors for an inflammatory response, which is innate driven. We think IL-6 is a very nice reflection of this, but looking at the mechanism and targeting mechanism, we do think that targeting IL-1 at this level will block at several levels, the induction of IL-1 beta itself, but also the IL-1 alpha. Now, is there some support for this? That's another thing. You can also argue that there might be a rationale for inflammasome inhibitors, and these are also actually tried in trials. Are there studies supporting targeted IL-1? Yes, there are a few cases that have been described. One of the most early one was actually a response to the cytokine storm and the HS score by calling it a HLH, a definition whereby the patients would fit this score, and then anakinra might be an option, and this was studied and done in Greece. In total, 8 patients, 7 from the ICU, and 3 of them died. And the dosage of anakinra was 3 times daily, 200 milligrams IV. They were compared historically to what we've known from secondary HLH, which is obviously not only COVID, where we do know that the mortality is pretty high. But that's just a hint for the patients that have a real HLH classification secondary, that anakinra might be worth to study and further investigate. Then along the way, there came a study from Cavalli saying 29 patients treated with severe COVID compared to 16 historic controls, non-ICU patients, importantly, because the timing of the targeted treatment is important, and they gave also high dose intravenously and found a difference in survival, although the historic controls obviously can be difficult as a matching. At least there was safety, and we had a hint from this study that anakinra might work. Then another study published a bit later with 52 patients with severe COVID compared to 44 historic, also non-ICU patients. And they were giving subcutaneous anakinra, lower dose, and there was also a reduction, or at least there seems to be a signal with ICU or death in 25% versus 73% in historic controls. And finally, a later, more recent study in PNAS studied 12 patients with severe COVID, gave 300 milligrams IV daily, where there was a clear fever reduction in 48 hours and rapid CRP. It's also in the line with our own experience with 22 patients. There was a clear response in inflammatory responses, but clearly there are larger randomized trials needed. Now, to finally conclude, we think that the timing is important when there is worsening at the setting where there is innate inflammation. Targeting IL-1 might have a good rationale for this, and even in the setting where there is dexamethasone, we might expect that there could be synergy at the stages. But the staging, the timing, and the target is very important. So I would like to thank many people that have contributed to all these studies, and thank you for your attention.